All right, we're about 3 minutes past our 10:30 start time. Just trying to give some more time for anybody else who is trying to join the meeting. But for those of you that are here, welcome. Welcome to today's office hours. We're coming off the heels of the February 6th Learning Collaborative, which was about the Consolidated Appropriations Act of 2023. And so thanks for joining the office hours today. So for today, basically, if you've been to these office hours in the past, it's going to be similar. So we're actually disabling the chat feature, so you're not going to be able to use the chat. But if you do want to send in any questions, feel free to move your mouse across the Zoom screen. You'll see the ribbon on the bottom. There's the QA button. You'll be able to send us questions via that QA tool down there. So make sure your volume is up so you can hear the speakers, and your microphones are actually going to be muted while the speakers are talking, but we'll open those microphones up for you when we move into that open Q&A session. All right, and we'll also be recording and providing captions. And if you don't see the captions down below, there should be a button you can select to have those pop up. Okay, well, got about 50 of us here, so why don't we go ahead and begin. So yeah, welcome everybody. This is our office hours time. We usually have these meetings a week or two after our Learning Collaborative meetings. And so like I was saying before, we met on February 6th for a Learning Collaborative about the Consolidated Appropriations Act. And so this was going to be a meeting to kind of go off of that. Sometimes we get questions based on that specific Learning Collaborative, and we'd like to bring those questions here to kind of go over. And then we also open it up for an open forum after these questions we'll present here in a minute. So my name is Mike Kadeen. I am the Program Support Unit Chief in the Correctional Facility Oversight Section here at DHCS. Glad to be here today. I'll be facilitating going over these first 4 questions that we received. So we'll kind of show you the question, we'll go over the answer, give time for any questions. After we move through those 4 questions, I'm going to pass it over to my teammate, Michael Gillis, who will then just facilitate the open part of this meeting with the open questions, if we have any. So again, meeting us from 10:30 to 11:30. We'll stay on time. Why don't we go to the next slide, and we'll just start checking out this first question that we received. So after that last Learning Collaborative we had, we were expecting to get more Consolidated Appropriations Act questions, but we didn't. So we did get 4 other questions that we thought we'd still go over, but we didn't actually have any specific CAA questions for this. So let me kind of go over what we do have and the answers. We'll see what your all reactions are if you have any questions, and then we'll just kind of move through these. Okay, so for the first question we had, for the managed care plan enrolled clients incarcerated over 28 days, should ECM providers bill fee-for-service until unsuspension or bill managed care plan, assuming retroactive re-enrollment? So we have our answer here. All pre-release services are billed fee-for-service via CAMUS and Medi-Cal RX, with the exception for circumstances, or the exception of circumstances where county behavioral health agencies bill short dole for receiving a behavioral health link. So pre-release care management services are billed fee-for-service to CAMUS during an individual incarceration, and justice-involved ECM providers must be enrolled as a fee-for-service provider or contract with a correctional facility to bill under the correctional facility's NPI when an individual is released from incarceration before managed care plan enrollment is activated. ECM providers must bill fee-for-service Care Management Bundle 5 for care management services. So it's pretty, similar to a lot of the answers we have here at DHCS, a little wordy, but that was our first question and answer. Any questions out there for this? And then there is a raise hand feature. Actually, never mind. I disabled the microphones, didn't I? So we're not taking those questions. How about write your questions down if you do have any of these questions. We'll move through these 4, And then if you had any questions on either of these four, we can go back after we open up your microphones. Sorry for that. Let's move to the next one. Okay, so question number 2. If an ECM provider gets a referral from a managed care plan for a client still incarcerated, must they provide ECM for at least 6 months post-release? So the answer, the authorization period, not receipt of services, for post-release ECM is 12 months post-release. And this will be updated in the next version of our policy and operations guide. One of the questions you may have coming off of this response is, when is the next policy and operations guide going to be released? I know somebody out there is thinking that. Right now, I just checked in with our leadership and where this is at. So right now, it's the guide that we have is being reviewed by our legal department. And so it's in the final stages of being reviewed here and approved. Okay, let's move on to question number 3. Okay, so for the third question, if a juvenile justice system anticipates getting a pharmacy license to give out medications under a county behavioral health system, in this scenario, what are the Medi-Cal pharmacy enrollment requirements to bill fee for service? So we reached out to our enrollment division on this one, and they're suggesting that we review the PAVE enrollment slide deck, which is posted to our JI website. After reviewing that, if you have any specific or direct questions or more detailed questions, we'd want you to email the inbox or our advisory group mailbox with those specific or more detailed questions after you've reviewed that slide deck. And so if you haven't seen that slide deck, I just posted it in the chat, so you could click on that and find that on our website. All right, question number 4. Can a correctional facility go live with all required care and services, but not enroll or bill Medi-Cal and still be compliant? So the short answer for this would be no. Correctional facilities need to be enrolled in Medi-Cal, and correctional facilities cannot bill without being enrolled. All right. So those are the 4 questions that we collected after the last learning collaborative. They're not CAA related, but maybe some of you have those other questions as well. At this point, I think we could open up the microphones, and if anybody had any questions about any of those 4, we could address those. And I'm trying to see if anybody's, let's see. Okay, so I see one answer in the Q&A. And I don't think that question was related to the questions we just asked or just went over. I do see one hand up. Looks like, is that Ron Klinger?
Yeah.
Hello.
Hi there. Thanks. Yeah, I just wanted to, on that 4th question, I wanted to clarify. It seems like the question was more about if they provide services but choose not to bill. Is there any compliance issues around that? Like, I know some of the early adopting counties they're providing a lot of services, but they're still getting the billing piece worked out. So I just wanted to double check on that.
Any of my partners in OSP able to address that?
I think I can take a shot at that.
Thanks,
Ron,
Ryan.
I think the key word here is compliance. Correctional facilities can provide services, but if we're talking about compliance, with the CAA or compliance with California's justice involved pre-release services legal requirements that are being administered by DHCS through this program. If we're talking about that type of compliance, then we're talking about being approved through DHCS's readiness review process and going live according to that process. And necessary as part of that process is enrolling as needed in Medi-Cal provider enrollment so that you can bill for the services that are part of the program. So it's the compliance part that I think is crafting our response on this. And I will just say that we received approval from federal CMS, which are the federal organization that is administering the implementation of the CAA requirements. We received approval from them to subsume those requirements into our JI pre-release services waiver program, according to the timelines of that program and all the processes of that program. So essentially, compliance with CAA is tantamount to compliance with our JI pre-release services program and the readiness review processes and go live that's associated with that. That's all.
Thanks, Brian. Makes perfect sense.
Right on. Thanks, Ryan. Any other questions out there? I did see one in the chat. Someone joined late and then wanted to see question number 2. Yeah, we'll put that out in the chat, or put that in the, we'll answer your question here. Any other questions though about those 4 questions? Got a smaller group today. I'm not seeing any other raised hands.
Sorry, I don't know how to raise my hand, but I do have a question. Hopefully you can hear me. Hi.
We can hear you.
So my question is regarding Section 5121 of CAA. Will there be an eligibility status reporting also? Do we report that in the screening portal as well?
Maybe Sarah maybe be able to help on that one.
Yeah, so I think what we're trying to communicate out is that by implementing the Justice Involved Reentry Initiative and providing those services under that JI aid code and everything that we've been talking about would be compliant with implementing this section of the CAA.
Okay.
So it wouldn't be any different. You would be providing those services under the Justice Involved program. The individuals would be youth or from former foster youth, which means they would meet the requirements of the program without having that health criteria required.
Right. The only question for me would be, how would we bill for dental? My understanding is dental is not covered under 1115. So, but here it will be. So if we submit in the last 30 days, we provided dental services and we submit claim and the JI code is under 1115, would we be paid for that or will that claim be denied?
I think I can take that one if that works. So I do try to remind myself to speak in specifics as much as possible. There are certain dental types of services that are required under the CAA. That's one of the elements that's slightly different from our original 1115 waiver design. We originally just said there were no dental services as part of the benefit package under the 1115 pre-release services. We always intended that some type of screenings were allowable. So even though vision services, quote unquote, and dental services, quote unquote, were not part of the benefit package, screening for needs for dental services or screening for needs for vision services were something that was allowable under the codes that we were authorizing under clinical consultation or other things. We are taking a close look at the codes we have right now under clinical consultation, and we may be making some tweaks to that to ensure that we can cover the type of dental screenings that are required under the CAA, which may be a little more intensive. And so we'll have additional guidance on what that looks like, but the correctional facilities will be able to bill for dental screenings that are required under the CAA, and we'll be subsuming that it will be a regular part of the 1115 waiver program, the pre-release services that are authorized. Does that answer your question?
The screening part, yes, but then for the services, I guess, like you said, you'll take a look at that and then
Yeah, dental. So the CAA requires to get nerdy about Medicaid terminology, there's a thing called EPSDT, early and periodic screening, diagnosis and treatment, I think, something like that. The CAA requires the screening and diagnosis portion of EPSDT. It does not require the treatment portion. EPSDT, for folks who know, is extremely expansive. It's the whole benefit package. It even goes beyond what's available for adults as far as treatment. So as we are checking to make sure we have everything we need covered under the codes that are available under pre-release services, it will be with reference to screening and diagnostics for dental screening. It will not be expansive of all types of dental treatments. Okay.
Okay, that answers my questions. Thank you. My second question is it was mentioned, I believe, the last session, that the former foster youth information we will see it in the portal once we are reporting, right? So we are not implementing CalAIM yet, and we do not have access to the screening portal. In the meantime, for those counties that do not have access to the screening portal, how would we know their status as former foster youth?
Brian, correct me if I'm wrong, but are we requiring counties to implement the CAA prior to go live for JI?
We are not. And just to say this all again, because it's a really important part, we say in our slide deck that we got authorization from federal CMS, who controls the CAA requirement implementation. We got an authorization from them to subsume the CAA requirements into our 1115 waiver pre-release services program. And that includes the timing of implementation. So everything we've told you in our guidance about the timing of implementation of the pre-release services program, that is directly now aligned with what is expected from federal CMS about implementation of the CAA requirements. So if you were planning to go live in July of 26, and you go live and you implement the pre-release services program in July of 26, and you don't do anything different until then, you are besides getting ready, you are in compliance with the CAA requirements.
Perfect. Thank you very much. That's all I have.
All right. And if you're still trying to figure out how to raise your hand, there's that button down there at the bottom on the ribbon, React. You can click that and find the raise hand button. Any other questions out there, though? We're about to move into an open Q&A process, too. So if there's any questions not related to the first four, which it doesn't look like there are right now, I think we're safe to move into the open Q&A portion of the meeting. And plenty of time left. I see Kathy's hand up. Hello.
Hi there. Just a quick question. I know this has been discussed. I just want to try to get some official clarification for my purposes. When a patient is seen during that eligible 90-day pre-release period, and they potentially are sent outside of the jail for services that may not be directly related to reentry care, but let me try to give you an example. They complain of an issue and they need to be sent out for an office visit to evaluate that situation. Will that offsite provider be reimbursed under the JI benefits from Medicaid, or are those services the responsibility of the correctional facility? And I'll add on to that to say, is it possible that some is covered under the JI benefits and some would be covered by the carceral facility, et cetera?
Thanks, Kathy.
And I understand emergency services would not be covered under JI, I apologize, but I'm referring more to just outpatient physician services.
Mike, do you want me to take a shot at this?
You can't see me on the screen, Brian, right now, but I was definitely looking at you. I think Brian might have
Felt it.
something to say on this.
Felt it. Yeah, so we've gotten a few questions that are similar from different counties lately about this. And I'm going to try to get the term phrasing right, and others on the team, as always, can please clarify for me if anything is needed. But I think the gist of it is, we have a package of services that are authorized under the pre-release services program. So if somebody has that JI aid code turned on and they are participating in the pre-release services program at the time, if they go outside of the facility to get some services, whichever of those services are part of the approved JI pre-release services package, those can be reimbursed by Medicaid during that time frame when the JI aid code is turned on. So for example, somebody goes out, they break their leg, and the correctional facility doesn't have diagnostic equipment or the proper equipment. They send somebody outside, and there's some imaging done. Imaging and diagnostics are something that is covered under the pre-release services program. That can be reimbursed. Now, who bills for it can depend on whether that provider is sort of working under contract with the correctional facility, and the correctional facility, I think, has the option to bill under their MPI, or potentially that provider, I think, could also bill directly to fee-for-service, as long as they're one of the allowable providers who are covered under that particular service that they're providing under the guidance for the JI pre-release services package. So when you say emergency services aren't covered, emergency services, from what I understand, is a package of things that are done in a particular location, an emergency room. Now, breaking that package of things that are done up, if there's diagnostics that are done and that's covered under the JI pre-release services program, which it is, that could also be reimbursed under this program. There may be other things that are done, surgical procedures or something that are done in the emergency room that are not part of our covered package of services, and those cannot be reimbursed. So really, it's all about what specifically we are covering under that package of services and digging into the details of what codes are covered under clinical consultation, what services are available under the other buckets of services, care management, diagnostics, medications, administration of medications, and the other services that are available, CHW services, et cetera. And now the only caveat I'll give to that is if somebody is actually admitted to a hospital, expected to be over 24 hours, that is not covered under the pre-release services program.
Understood.
But that can be covered under another MCIEP, I think is what it's called, program.
Correct.
So yeah, I'll stop there.
Okay, so with that being said, I know that it has been requested on previous calls to receive a list of covered codes. Will you be publishing the code set that will be covered under these JI benefits?
We have some guidance now that's available about the codes that are available. I think we are working on a way to provide that information in a little bit more user-friendly of a format.
Okay, and then just to clarify, so this community provider that provides the services may not be involved in the reentry care management process. Would they be able to bill Medicaid the way they always bill Medicaid and receive reimbursement for those JI, or would they be expected to bill specific modifiers or in some way indicated as JI driven on their bill?
Definitely would have to include the specific coding and whatever modifiers are required for the JI pre-release services to get reimbursement for that. nothing that doesn't follow that specific guidance for this program would be reimbursed because it would get bounced for the person being incarcerated, and most things are generally not reimbursable for incarcerated folks. Having said that, the system that they use and the process would be the same if they're accustomed to billing fee for service for the services. The only difference would be if we're talking about a behavioral health service, like the behavioral health clinical consultation services are billed fee for service through CAMIS, which normally the behavioral health Short Doyle County Behavioral Health Agency services are billed through Short Doyle. So that's one change. But otherwise, providers who are familiar with billing fee for service, I think it should all be familiar and the same, except for the modifiers and specific coding requirements.
So, and if there's other questions in line behind me, I can certainly take this off, but I think this is the issue I've been having trouble clarifying, because my concern is that, taking your example of a broken leg, if we send someone out to be seen about the leg and that office visit is covered, if that office visit code happens to be one of the codes that is covered, but that provider is not part of, like, no one put in the HRA, or it's not, certainly not part of the reentry plan that this person might break their leg. So that is a service that comes up during the 90-day period. They go out for that consultation. If the jail advises that physician to bill Medicaid primary, but that physician may or may not be familiar with how to bill for JI, especially if that's a physician who's going to bill on a professional claim form, would CAMIS accept those professional claim forms, process it based on the member's eligibility aid code, and pay that provider for any of the services that are covered under the JI package? Or would something about the way that physician bills need to be specific so that that reimbursement is eligible? Does that make sense?
Yeah, I think so. I'm not a billing expert per se, and if we have any of our CAMIS folks on, they can certainly chime in and provide more detailed clarification. But I think the answer is that anybody who's billing for JI pre-release services will need to follow the specific billing guidance that is required for these programs. I can't tell you exactly what that is on the phone, where there are modifiers required or where there are specific codes, but there are. And so we have a provider manual section related to JI. Again, it doesn't necessarily provide, we're looking for more user-friendly ways to provide that information, but anybody who's billing will need to follow the specific guidance for billing for JI pre-release services. Otherwise, the claims will get denied. How that technical assistance gets to those providers is a question, and certainly we're happy to talk with what the best way to do that is.
Thanks, Brian. So that's my concern, is that these correctional facilities are attempting to understand and learn the process for billing these JI specific codes, but they certainly aren't in a position to then educate community providers how to bill their claims specifically for JI when it's something like this broken leg scenario that's not related to the full reentry services model that we've kind of been talking about. You know, these might not be providers that are helping every patient. It's the ortho provider who's assisting this issue in their specialty.
Yeah, it may be pros and cons of whether you sort of quote unquote bring those providers under contract with the correctional facility for those services, and then the correctional facility bills directly to DHCS. May be easier in some cases, or it may not. I can't say for sure.
So in that case, if the correctional facility is contracted with those providers and they pay them per the existing contract, the correctional facility can still then turn around and bill for that service to recoup.
I believe that is correct. If anybody on the line here from DHCS's team thinks anything that I've said sounds not quite right, please let us know, or if we want to go back and double check, but I believe that all is correct.
Okay, and that helps. That helps as well. That's workflow that we could certainly work with. I just wanted to make sure, since the correctional facility did not provide the actual service, that they could still bill for it. Does that make sense? Because that provider.
Yeah, I mean, I think what we're talking about is a slightly broadened definition of what is an embedded provider. We have talked about embedded providers as people who are under contract to do regular services with the correctional facility, who come into the facility to provide those services. I think this could be just a slightly broader definition of what is treated as an embedded sort of provider.
Great. Thank you so much.
Right. And I'll just provide another opportunity if anyone want to raise their hand and ask another question, or we'll just kind of, sounds like we're easing into our open forum area anyway. Got another 25 minutes for this call. Okay, with no other questions about those four that we presented, I'll just pass it over to Michael G, and we can kind of go through the open forum, and then that'll be our meeting. All right, Michael G.
All right. Good afternoon, everyone. Now we're transitioning over to our open question and answer portion of the Learning Collaborative for today. We request that you raise your hands, put your questions in the question and answer chat box, or place your question in the chat itself if you're having any issues raising your hand, coming off mic, or any of the like. And with that, I will also be reviewing some of the questions that we've previously received from our open Q&A during this time. One of the questions that we received from an anonymous participant: do all of the requirements of the requirements to complete the HRA need to be on one individual form, or can they be across multiple forms? Does the HRA need to be submitted along with every claim for services? What is the time frame for completing a new HRA for a patient who is incarcerated versus using the last form? And we are going to follow up with this request specifically, so we request that you submit this request to the CalAIM Justice Advisory inbox for some additional research and discussion. For the slides themselves, we will request that you just directly reach out to us, same aim to that CalAIM inbox. I'm going to drop it in the chat just to be safe so that everybody sees it as well. Apologies. For some reason, So dropping that in there. So please feel free to reach out to us directly for the answers to those first two questions. And then same thing for the second question. The second question: if an ECM provider gets a referral from an MCP for a client still incarcerated, must they provide the ECM for at least 6 months post-release? The authorization period, not recipient of services, for post-release ECM is 12 months post-release, and this will be updated in the next version of the Policy and Operations Guide. And of course, Brian did provide the answer for section 5121. That answer was provided live. And currently, we do have one additional open question on when a county e-jail is enrolled as a clinic to obtain an MPI through PAVE. They are required to enroll each facility on campus associated with the sheriff. Are they required to enroll each facility on campus associated with the sheriff office separately? Additionally, should billing be tied to the specific facility where the patient receives services, or can the biller just use the main jail location NPI? And for this,
Michael, we're going to take this one back, I think, at least part of it.
All right, thank you so much, Ashley. So this will be an additional question that we're going to provide additional clarification and responses on. So my apologies on that one. Are there any additional questions from the group that we have today? Please feel free to raise your hand or come off of mic if you're having issues raising your hand, and feel free to ask any additional questions. All right, Kathy, go ahead. I see your hand is raised.
Hey, Michael, I know that this has been something we've asked before, and as things have changed and DHCS continues to learn, I'm curious on the HRA and the reentry care plan, does DHCS plan to put out like a standard template, or is this still something that is up to the discretion of the correctional facility to build based on the policy guide?
Well, this is Brian. I don't believe DHCS has any plan to build a standardized template for this. Is anyone else aware of any such a plan on our team?
I would confirm that's my understanding as well, Brian. We have been encouraging facilities to utilize the standard template provided in the P&O or any of their own.
Yeah, so what we've got available in the P&O, everybody knows this, there are requirements. There are specific elements that have to be included in the HRA, but we have not provided a standardized template. We've had a few questions about that, and we've said, we'll go back and think about it a little bit, but I don't believe we have any plan to do that at this time.
Thank you. That's what I thought. And the facilities we work with are doing just that. I just wanted to confirm. Some of them were concerned that their efforts might then not be in line with what you guys were expecting if you had made plans to do so. So I just wanted to verify. Appreciate it.
Yeah, no, I think just in the way of collaboration and encouraging collaboration, this is going to transition to the managed care plans, and it's going to transition to the ECM providers who work for the managed care plans. Some sharing of notes between the correctional facility and the managed care plans in the area might be good as that HRA template is being built. It probably would be good if there's some level of alignment between how the ECMs and the managed care plans look at the care plans they are required to build for their folks today, and how the correctional facility is building that template. I saw Ron Klinger's hand pop up. Ron, did you have a comment about that, or was it another question?
There was a comment about that. I think Dawn had her hand up first, but just really quickly, we've shared our template that we developed at Partnership Health Plan with CDCR and several of our county partners. And if anybody's interested, we're happy to share it out to anyone who wants to see it. It meets the specific ECM requirements and is a good guideline.
Wonderful. Thank you so much. And then Dawn, we also saw your hand up. Was it in relation to this question, or did you have another question?
Thanks, Mike. I actually have a separate question. The question I have is for correctional facilities that have secured product or drug through DGS, through contractual arrangements. Who do they bill if they are using drug that was procured through DGS versus the state?
So I believe, and I will have to take this one back to just be 100% certain, but I believe, and I will defer to Brian and Caroline on this as well. They have much more understanding of the DGS pricing agreement than I do, but I believe anything that is billed via the DGS pricing agreement should not be billed via Medi-Cal or Medicaid.
Okay, because I know, so for example, I work for Gilead Sciences and we have contracts with the state, but we also have contracts with DGS for the correctional business. So it's, we've had a lot of internal dialogue around how this is going to impact our business, and we're just looking for some guidance on how that will work.
I can take this. Hi, this is Caroline Dunlop. So the Pharmacy Benefits Division did create some guidance for counties that do have contracts with DGS. In the readiness assessment and prior to, but in the new readiness assessment, we are requiring correctional facilities to attest that they do participate in DGS contracts, that they cannot and will not bill Medi-Cal for any medications that are purchased through a DGS contract. So it would be up to the correctional facility to create their own process in-house to keep a separate inventory or track the medications that do come in. I know some of the counties have suggested that they're going to use a different local pharmacy for specifically for the medications in hand upon release. So those will be billed directly from the pharmacy, as opposed to taking those medications out of any of the DGS purchased inventories. So I can send you a copy of that guidance if you want to put your email in the chat box, or if you email that question to the CalAIM Justice Advisory email box, it'll be sent to me and I can respond and send you a copy of the DGS options. And again, this is guidance only. We are not creating policy regarding DGS, other than requiring that the correctional facilities attest they will not bill Medi-Cal. Does that answer your question?
Yes, it does. Thank you, Caroline.
You're welcome.
Well, thank you so much, Caroline. Thanks for that answer. All right. Do we have any additional questions? Not seeing any hands raised at this time. We'll give it one more moment for any additional last lingering questions. But otherwise, if there are no additional questions from our county representatives and our external stakeholders, we would end the meeting early and refund some of your time to you.
I will just say there is a question about whether the 834 file that DHCS sends to managed care plans will at some point include the location of the member who is incarcerated. This is part of the information exchange that we do to inform managed care plans that they will have a member coming their way who's participating in the pre-release services program. And the question is, will that information we're transferring to the managed care plan say which correctional facility and where that individual is located? The question implies that that information is not currently provided. I don't have an answer, but we'll go back, take that back and try to get an answer.
Thank you so much, Brian. There's also an additional question. Is a new readiness assessment coming out that is more current than the February 2024 version? I thought I heard Caroline Dunlop saying there will be a new readiness assessment. Yes, we will be releasing a new readiness assessment once the policy and operations guide is released. That will align with any changes that have been made with the policy and operations guide, and potentially also, in some instances, clarify what our expectations are and what any additional documentations that we're seeking. That will be coming within the next few weeks, fingers crossed, along with that policy and operations guide. So it'll be policy operations and then the new readiness assessment. All right. And then, Ron, I noticed you've got a couple of people requesting the additional information in the template, if possible. It looks like we got Santa Cruz, thinking San Bernardino, I believe, as well. So if you could share that template with us, we'd be more than willing to also share it out as an attachment with this meeting. And then yep. And then information on the status of the indicator would also be great. The pause, reset, etc. information. So with that, Ron, I will defer to you if you have any additional clarification on the question before we can provide some additional information.
Yeah, thanks, Michael. No, it was just kind of like to tack that in as Brian mentioned, if there's some discussion being had about adding additional information to the 834, that would be a really helpful piece to have as well. So we can better kind of plan, right now it's just on and off. So knowing if it's been paused or if it's going to be reset for another 90, that kind of thing would be great. That's all. I just want to throw that in there.
Wonderful. And we can take that back and provide more information on that.
And while I'm on, Brian, did you see what I put in? Do you want me to send our template to you directly? Because I did share it with Kamya a couple of weeks ago. I just wanted to check and see what you want me to do with that.
Yeah, if you could send it directly to me, that would be helpful. Thanks, Ron.
You bet.
Wonderful. Thank you so much. All right. I don't see any more open questions in our question and answer. And no hands are currently raised. Just going to take an additional moment. Are there any additional questions? All right. I will take that silence as golden and we are good to go. Thank you all so much for joining us today for our Learning Collaborative office hours. Please, if you have any additional questions that come out after the meeting, please feel free to send them over to that CalAIM Justice Advisory inbox, and we will be forwarding the notes and the minutes from this meeting at a future time. Thank you all so much for joining us today, and have a lovely rest of the day.